Okay, everyone, welcome back. Okay, I did start another recording now. It's getting recorded. Can you see the blank screen?
Yes, you can.
Okay, thanks. Okay, that's about, we were discussing endocrine before we left, correct? So now let's move on and tell me about the anterior pituitary hormones. What are the anterior pituitary hormones? We call it as demonic flat pig, correct? So FL, FSH, LH, ACTH, TSH, prolactin, growth hormone. FSH-LH cells secreting them, they act on the gonads. Therefore, the cells secreting them are the gonadotropes. ACTH cells are called as the corticotropes. TSH secreting cells are the thyrotropes. Prolactin secreting cells are the lactotropes or mammotropes. And what are the growth hormone secreting cells called as?
Somatotrope.
Somatotropes. So if you look at this, which are the acidophilic cells?
The
Growth hormone and prolactin.
So the hormone secreting growth hormone and prolactin. Good. So somatotropes and lacto or mammotropes are acidophilic. Rest all of the cells, gonadotropes, will be basophilic. So prolactinoma will be an acidophilic tumor. Growth hormone excess can be a tumor which is an acidophilic tumor. But all the other cells, if they are involved, there will be a basophilic tumor. Give me a condition which compresses all these cells. Where the cells get compressed. Which tumor was it?
stalk lesion.
I told the cells are getting compressed. So it has to be a space occupying lesion. Where was that?
Pituitary stalk.
Craniopharyngioma. So that's a tumor, and any space occupying lesion will compress all these cells. Stalk lesion is a condition where the nerves and blood vessels are cut. So that means the releasing hormones and dopamine cannot reach. But anterior pituitary cells are okay. The anterior pituitary cells are okay, but releasing hormones and dopamine cannot reach because the nerves and blood vessels, they are getting affected, they are cut. Okay. So once you know this, next let's go on to growth hormone, the anterior pituitary actions. So we were discussing what is albinism, pigment abnormality, which enzyme converts dopaquinone to pigments? Tyrosinase. So this individual having tyrosinase deficiency can have albinism. Generally, we don't have lots of MSH. What's the other byproduct? What's the precursor for MSH?
POMC.
POMC. So it generates MSH, but majority of it gets converted to what in you and me? ACTH.
ACTH.
So because of structural similarity, ACTH can also bind to the melanocyte receptors and lead to pigmentation. So any disease where ACTH increases can cause hyperpigmentation, but it was classically described in what? We are adding color. That's how we remember. So which disease was that?
Addison's disease.
Addison's disease. Okay. Next, if it's an anterior pituitary lesion, hypothalamic tumor, anterior pituitary tumor, hypothalamic lesion. Lesion is a defect, tumor is excess, okay? And Laron dwarfism. What was Laron dwarfism?
Growth hormone receptors.
Growth hormone receptors are not working. So give me the growth hormone levels, GHRH levels, and IGF levels. What is IGF? What's the other name for IGF?
Insulin-like growth factor.
Insulin-like growth factor or somatomedin C. Who produces it?
Liver.
And what's the requirement? Growth hormone will bind to receptors and stimulate IGF. Why? Growth hormone, its main action is on the bones. So what are the two cells which helps in bone growth? Osteoblast and epiphyseal growth is brought about by chondrocytes. Growth hormone has receptors for what? Where are the receptors present? Only on blast. It cannot bind to chondrocytes. Chondrocytes have receptors for IGF or somatomedin C. So that's the reason growth hormone will stimulate liver to secrete IGF, because IGF is required for proliferation of chondrocytes, and that causes epiphyseal thickening and bone elongation. So if you don't have IGF, bones cannot grow, in short. Okay. So anterior pituitary lesion, tell me what happens, where is the problem?
The anterior pituitary.
Anterior pituitary. So growth hormone will decrease.
Less.
GHRH is trying to correct it. It will increase. And what will happen to IGF or
Decrease.
somatomedin? It will decrease. Hypothalamic tumor. So what happens to GHRH?
Increase.
Increase. Growth hormone is increasing. IGF will also increase. Anterior pituitary tumor. Start from there. What is increasing first?
Growth hormone.
Growth hormone increases, so IGF will also increase. And due to negative feedback, what happens to GHRH? It will
Decrease.
decrease. Hypothalamic lesion. So hypothalamus has a problem. GHRH will be less, growth hormone will be less, IGF will be less. Neuron dwarfism, the receptors are not working. So the liver receptors won't work. So what will happen to IGF?
Decrease.
Decrease.
Decrease, so the child is short. So looking at it, what will the anterior pituitary and hypothalamus try to do? Correct.
Increase the growth hormone and the GnRH.
GHRH. So the hypothalamus and pituitary is okay. They try to compensate by increasing them. Okay, that is seen in neuron dwarfism. Once you know this, can I erase this?
Yes.
Now let's talk about, so that was the problem. So if growth hormone is less, what will it give rise to? Dwarfism. So growth hormone helps in bone elongation. What does it do to blood sugar? For energy, for growth I need energy. So what does it do to blood glucose? Increase.
Increase.
For growth I need proteins. So what will it do to proteins? Synthesize. It will increase sugar by breaking fats. So what does it do to fats? Lipolysis. So in growth hormone deficiency there is dwarfism. Give me another condition, endocrine cause for dwarfism. Differential diagnosis. That means another endocrine cause.
Thyroid.
Thyroid deficiency. What do you call these children as? Cretinism. Why? What's the main difference? This child will have mental retardation. Why? Because T3, T4 helps in myelination of nerve fibers. And if the myelination is defective, there will be mental retardation. Growth hormone deficiency, there is no mental retardation. Thyroid helps in ossification, correct? So what will happen to the child bones? They will be infant-like. Infantile means the upper half of the upper part of body is greater than lower part. Big head, large trunk, short limbs. In thyroid and pituitary dwarf, this is called as pituitary dwarf, correct? The child is short, but the body proportions are maintained. So that is according to the chronological age. So to tell that the child has cretinism and defective myelination, what is that one sign which tells that myelination is defective? Babinski's sign. So if they tell Babinski is positive, so that means the myelination is inappropriate. Babinski's is stroke the lateral aspect of the foot, not on the hand, on the foot you do. Imagine this is the foot. Stroke the lateral aspect up to the big toe. So normal you and me, we will flex and withdraw the foot. But in this child, the big toe moves upward and there's fanning of the other toes. So that is positive Babinski's, which indicates that myelination is defective. So that is one sign in cretinism. I saw a question where they told Babinski's is positive. So that's nothing but in cretinism it can be positive. So these are the differences. Next, if a child comes with growth hormone deficiency, the child is short, give them GHRH. Following GHRH, if growth hormone increases, where is the problem?
Anterior pituitary. Oh, I'm sorry.
Growth hormone is increasing, so anterior pituitary is responding. So
Hypothalamus.
hypothalamus. Even after giving GHRH, if growth hormone does not increase, the anterior pituitary is not responding. Okay. Next, if you have questions, please ask. I'm just going because of time constraint. I'm just going on covering all the concepts. Next, if growth hormone is high before puberty, what will it give rise to?
Gigantic.
Before puberty, the individual is very tall because bones continue to elongate. So that is called as gigantism. After puberty, the height may be relatively normal. They might be slightly tall, but not as tall as gigantism. But all the cartilaginous portions will enlarge. So that's why it's called as acromegaly, where all the acral, large hands, large feet, all the acral portions will enlarge. What can happen to blood sugar in this individual? Both. In both of this, blood sugar can increase, plus proteins. What will happen to proteins?
Synthesis or
Increase synthesis. It will accumulate, giving rise to edematous changes. Why do these individuals, why can they have gynecomastia, galactoria, with or without galactoria?
Structural similarities to prolactin.
Good. Growth hormone is structurally similar to prolactin. So if growth hormone increases, it can bind to prolactin receptors on the mammary gland, giving rise to gynecomastia. Next, why will they have vision defects? Bitemporal hemianopia. It's excess. So we're talking about tumor. So
The optic chiasma.
this tumor might compress the optic chiasma. So compression of optic chiasma can cause visual defects. Next, if you look at prolactin, prolactin is secreted from the anterior pituitary lactotropes. Normally in males and non-pregnant women, it's kept at lower levels. Why? Which is the hypothalamic hormone which inhibits it?
Dopamine.
Dopamine normally inhibits it. But in pregnancy, you want it to increase, correct? So in pregnancy, dopamine levels decrease. And what else in pregnancy can stimulate the lactotropes to secrete prolactin?
estrogen.
Estrogen. The first hormone is estrogen. Plus in pregnancy, TRH can also increase significantly. Normal action of TRH is to stimulate thyrotropes. But when in excess, it can also stimulate lactotropes and prolactin will increase. Okay, so these are the factors. Plus during child breastfeeding, milk injection, then oxytocin also can stimulate anterior pituitary prolactin secretion. But what's the action of estrogen and progesterone to some extent? They can stimulate lactotropes to secrete prolactin, but you don't want the mother to lactate from first trimester. So what will estrogen and progesterone do? They have an inhibitory effect on protein synthesis. So what are the proteins it will block? The milk proteins, casein and lactalbumin. So what does estrogen progesterone do? They just maintain reservoir of prolactin in the blood, but it will not allow it to act because it inhibits protein synthesis. So what happens after the child is born? The estrogen progesterone is withdrawn, inhibitory effect is lost, and because of that prolactin can immediately start working and there is milk production happening immediately. If you don't have enough in the blood, then milk production will take weeks, which cannot happen, right? So estrogen progesterone sees to it that prolactin is ready to act, but it will hold it back so that milk is produced only when required. So that's one thing they also ask you in questions. What's the effect of estrogen or progesterone on milk protein synthesis? It has an inhibitory effect. So what's tumor of these lactotropes known as? Prolactinoma, where prolactin is secreted in excess. So what are the common features both in males and females? Gynecomastia, galactoria. What are the features unique in women?
Amenorrhea.
High prolactin can suppress GnRH, FSH, Good. So they will have history of amenorrhea, infertility. In males, they can have infertility. Testosterone will be less, spermatogenesis will be decreased. So they will have history of infertility, impotence, etc. How will you treat? If it's a tumor, you have to remove. But which drug can you give to suppress prolactin?
Bromocriptine.
Dopamine agonistic drug. And what's the name of the drug? I expect you to remember this. Bromocriptine. So bromocriptine helps in suppressing prolactin. What is lactational amenorrhea? Break the word. Amenorrhea is no menstrual cycles during lactation. You already told me the reason. So start during lactation. What increases? Prolactin,
Correct.
which will suppress GnRH, FSH, LH, and that will decrease prolactin. That will decrease or cause amenorrhea. Okay, so increased prolactin suppresses GnRH, FSH, LH, resulting in amenorrhea. So if you have to summarize, GnRH, FSH, LH axis. So what are the conditions which suppress GnRH, FSH, LH, resulting in amenorrhea? So what are the different factors? Increase in prolactin can suppress GnRH, FSH, LH. When women are
Increase in
stressed, TRH. So when TRH increases in thyroid diseases, it won't directly suppress, it stimulates prolactin secretion, so that will suppress GnRH, FSH, LH. When women are stressed, their menstrual cycles can get affected, correct? So stress, so related with the stress regulating hormone, CRH. So increase in CRH can decrease GnRH, FSH, LH, resulting in amenorrhea. Okay, so these are the different conditions where it can cause cessation of menstrual cycles leading to secondary amenorrhea. Disorder. Comment what happens to FSH, LH, ACTH, TSH, prolactin, ADH. So let's start with Sheehan's syndrome. First tell me what is Sheehan's syndrome. She for a woman. So something related to a woman. What was it?
Hemorrhage
Necrosis
because
of
gross.
genital gland.
A woman should have history of recent childbirth during which she should have had postpartum hemorrhage with severe blood loss. There might be history of blood transfusion. So that tells you that her bleeding was very severe. So following postpartum hemorrhage, there was anterior pituitary necrosis. So it's postpartum anterior pituitary necrosis. So why anterior pituitary was affected? Because during pregnancy the anterior pituitary enlarged. Why? Which cells were increasing activity or stimulated?
Lactotropes.
Estrogen kept stimulating the lactotropes, so anterior pituitary enlarged and depended on a good blood supply. So if she had postpartum hemorrhage, her pituitary blood supply was affected, and that resulted in pituitary necrosis. Posterior pituitary did not have any stimulus, so that won't be affected. So what will happen to all her flat pig hormones?
Decrease.
FSH, LH, ACTH, TSH. Lactotropes are also necrosed, so it has to decrease. But posterior pituitary was not affected, it remains normal. Craniopharyngioma. So craniopharyngioma is a tumor which is occupying, it is like a space occupying lesion in the pituitary stalk. So what will it do to the anterior and posterior pituitary? It will compress. So don't worry about hypothalamic hormones. What has happened to the anterior and posterior pituitary cells? They are compressed. So what will happen to flat pig hormones?
Decrease.
Decrease.
All will decrease. Some of you are getting confused with prolactin. You're telling me dopamine is not there. Yeah, if dopamine is not there, doesn't matter. What has happened to the lactotropes? The tumor is compressing them. So what should happen to prolactin as well? The tumor is compressing the lactotropes. So doesn't matter if dopamine is there or not there. Lactotropes are compressed. And if they are compressed, can it secrete the hormone? No. So prolactin should decrease. What will happen to ADH?
Decrease as well.
Decrease. So what type of insipidus does it bring about? Neurogenic diabetes insipidus. Last one, pituitary stalk lesion. So what is a stalk lesion? That's a lesion of the nerves and blood vessels. The anterior and posterior pituitary is fine, but the blood vessels were cut. Actually it's the nerves, but when there is a lesion, it will also destroy the blood vessels. So the releasing hormones could not reach, dopamine could not be secreted to reaching the pituitary. Due to which, what will happen to flat hormones? Decrease, because the releasing hormones are not there. And because dopamine is not reaching the pituitary, the lactotrope is okay. So what will happen to the prolactin secretion? Increase.
Decrease.
Increase.
ADH eventually may be normal initially may be normal, but if it continuing this lesion, then new ADH cannot be secreted, so eventually it can decrease. Okay, that's about the 3 diseases which affects the anterior posterior pituitary. Next, posterior pituitary is easy. In renal also we have discussed it, so only the clinical stuff I will revise here. If patient has high ADH, cyclic AMP is high, what's your diagnosis? What's the diagnosis?
Diarrhea.
Pardon me? Disease.
No, I'm sorry.
Disease.
Polyuria. Wait. What's
ADH
the little
is
urea?
high. Is it working?
Yeah, it is.
It is. So what's the disease where ADH is high? SIADH.
SIADH.
And what are the causes for SIADH? Any hypothalamic posterior pituitary tumor, or what's the ectopic cause? Root cell carcinoma of the lungs. So here, what will happen to the urine osmolarity? ADH is high and it's working. So what will happen to the urine osmolarity? Concentrate
high.
Or dilute? Concentrate. So what will happen to the osmolarity? High. So what will be a differential diagnosis for high ADH? Nephrogenic diabetes insipidus. So in nephrogenic insipidus, ADH will be high, but what will happen to cyclic AMP levels? The receptor may not be working. So what can happen to cyclic AMP levels? Decrease. Okay, why? Nephrogenic, there's a problem with receptor. If there's a problem with receptor, then cyclic AMP will be less. What's another way to differentiate? Urine. ADH is high, but it cannot work. And if it cannot work, what will happen to the urine? Dilute or concentrate?
Dilute.
Dilute. So what will happen to the urine osmolarity? Decrease.
Increase.
Then neurogenic insipidus, what's the problem? ADH is not secreted, so cyclic AMP also will be less, and urine is dilute. So this will be neurogenic insipidus. So in diabetes insipidus, patient comes with polyuria, polydipsia. So what are the differential diagnoses for this polyuria, polydipsia? Insipidus, mellitus, lithium carbonate therapy, and diuretics. I am asking you causes for polyuria, and when you lose water, we also feel thirsty. So insipidus, urine will have lots of water, so urine osmolarity is very dilute. Mellitus, urine has sugar.
High.
So urine osmolarity has to be less than 300, but it will be in the 200 to 250 range. Lithium carbonate causes a defect in aquaporins, causing nephrogenic diabetes insipidus. Therefore, again, urine osmolarity will be very dilute. Diuretics, what happens? Urine contains sodium. So what will happen to fractional excretion of sodium in diuretics?
Increases.
It's high, greater than 1%. Tells that sodium is present in the urine. Okay? And if it's a loop diuretic, how much sodium is excreted? How much of extra sodium?
25%.
25% of sodium gets excreted, because normally loop diuretics reabsorb, loop of Henle reabsorbs 25% of sodium. A loop diuretic will cause excretion of 25% of the sodium. So you rule out sugar. Patient is not on any medication, so you know it is diabetes insipidus. So now, how will you confirm it's diabetes insipidus? Perform the water deprivation test, dehydration, water restriction test. What's a normal response when you don't drink water? What happens to urine osmolarity?
High.
High. But if urine osmolarity continues to be low even after water deprivation, you have confirmed it is insipidus. Now you want to establish whether it's neurogenic or nephrogenic. So what will we do? We will give injection arginine vasopressin, which is nothing but ADH. So if it is neurogenic, what should happen to the urine osmolarity? If it's insipidus, the urine osmolarity is less when they come, right? So their baseline osmolarity is less. On giving ADH in neurogenic, what should happen to the urine osmolarity? Will they respond? Will they respond?
No.
Yes, they
Neurogenic.
will.
Neurogenic, what was the problem?
They will respond.
They didn't have ADH, right? So if you give ADH, they will respond. So what will happen to the urine osmolarity? Increases. In nephrogenic, the problem is with the kidney. So even if you give ADH, will they respond?
No.
No. So what will happen to the urine osmolarity? It continues to be
Remain low.
So if urine concentrates, that is cranial. C for C. If urine concentrates, it's cranial. Cranial is nothing but neurogenic. If urine continues to be dilute, it is nephrogenic. Okay. Craniopharyngioma and other things we have done in renal. So I'll move on to thyroid. So if you look at thyroid gland, posterior pituitary, the other hormone, what was it? Oxytocin. So tell me about oxytocin. What's the two main actions? Milk ejection.
Milk rejection and milk
Parturition.
parturition.
Ejection and letdown is the same. Okay, so milk ejection or letdown is the same, and parturition. So what should be the stimulus? Go by this. Milk ejection, what's the stimulus?
Suckling.
Suckling. Parturition, what's the stimulus? Stretch.
Contraction, so stretch.
The stretch of the fetal head on the dilated cervix. So that stretch will cause oxytocin secretion. What emotions can stimulate oxytocin?
Isn't it hearing the baby cry?
Baby cry, sight or sound of baby's cry can also stimulate oxytocin secretion. And then these actions, you know, the milk injection and parturition reflex. Now coming to thyroid gland, we'll start with hormone synthesis. We start from the blood surface where the substrate will enter the cell and hormone synthesized is stored in the lumen. So what's the substrate for thyroid hormone synthesis? The follicular cell
Iodine.
has a sodium iodide pump through which the iodide from blood enters the cell. That's the iodide uptake. Is iodide the reactive form?
No.
It has to get converted to the reactive form iodine. So that's the oxidation. Which enzyme?
TPO.
TPO.
Thyroid peroxidase. Meanwhile, thyroglobulin binds to tyrosine. It will enter the follicular lumen. Where this thyroglobulin tyrosine will interact with iodine. Iodine interacts with tyrosine. What's the step?
Iodination or organification.
Iodination or organification. Which enzyme?
TPO.
Same, peroxidase. So if iodine reacts with one site on tyrosine, it's monoiodotyrosine. If two sites react, diiodotyrosine. Now several complexes of MIT-DIT thyroglobulin are formed. So what's the last step? These two complexes will react. So what's this last step called as?
Coupling.
Coupling. And what's the enzyme again? Peroxidase.
Peroxidase.
So if one mono reacts with adjacent di, what do we get?
T3 and T4.
Di and di reacts T4. Some of the MIT-DIT fail to react, so they'll remain as such. So this is how thyroid hormone is stored in the bound form. So they ask you this, it's bound to what? It's bound to thyroglobulin. Okay, it's binding to thyroglobulin. So that's the storage form, correct? Now what will stimulate the release? The regulatory hormone of the anterior pituitary, which is TSH. So TSH receptors are on the follicular cell. So if they ask you a question that the TSH receptors are defective, where is the defect? On the follicular cells. If TRH receptors are defective, where is the defect?
Hypothalamus.
TRH receptors. Where are the TRH
Anterior.
receptors? In the anterior pituitary. So always the receptors are lower down. For TRH, the receptors are in the anterior pituitary. For TSH, the receptor is in the thyroid gland. So some questions, they talk about these receptors being knocked off. So always remember, TRH receptors means anterior pituitary is having a problem. TSH receptors means follicular cells have a problem. So otherwise, TSH will stimulate and then this complex re-enters and all the bonds break by lysosomal enzymes. MIT-DIT will get recycled by deiodinase enzymes. And what will happen to the T3 and T4? They get released. So the circulation, which is more dominant, or in other words, whose concentration is more in circulation?
T4.
T4 is in higher amounts in circulation. Therefore, that has a greater influence on negative feedback, but even T3 can cause negative feedback. But because T4 is the circulatory form, it will have a greater influence. Because T4 is higher, it will have a greater affinity for the binding globulin. But why in the target tissue, we are telling that T3 is more the physiological active form of thyroid.
It binds to the receptors.
Good. Activity is based
Has
on
higher affinity to receptor.
receptors, correct? So T3 has a greater affinity for the receptor. So if they ask you what's the physiologic active form of thyroid hormone, T3. So in the peripheral tissue, majority of T4 will get converted to T3. Which enzyme? Deiodinase. So in that process, there's a reverse T3 which is formed, which is just an inactive byproduct. So in questions, if they are telling you that role of reverse T3, just remember it does not have any function. It's the T3 which is physiologic active form of thyroid hormone. So once you know this, the synthesis, let's talk about drugs. Give me the negative feedback effect where high iodine inhibits the pump. What's that called?
Wolff-Charoff effect.
Wolff-Chaikoff effect. And this has been used where?
Exposure to nuclear emissions.
Nuclear emissions. The danger is they have radioactive iodine, which can lead to thyroid cancers. So to prevent that, what do they give them? Potassium iodide tablets before or immediately after exposure. So this potassium iodide will saturate the gland, so that will prevent the uptake of radioactive isotopes. That's utilizing Wolff-Chaikoff effect. Give me drugs which block the pump uptake.
Thiocyanate.
Perchlorate, thiocyanate. So they may either ask you the drug or they may give you the drug and ask you for the step. So perchlorate blocks which step? Sodium iodide pump. It blocks the iodide uptake. Give me drugs which block TPO.
Methimazole, carbimazole,
Methimazole, carbimazole and propyl
propylthiouracil.
For long-term management, we will give methimazole, carbimazole. It has no liver toxicity. But in acute conditions, pregnancy or acute increase in thyroid hormones, we will give PTU. So they might ask you either the name of the drug or the steps they block. So what are the steps they block? Oxidation, iodination or gamification, and coupling. Give me a disease where TPO levels are depleted. Give me the disease where TPO levels are less, they are destroyed. Which disease was it? Autoimmune.
Thyroiditis.
Hashimoto's
Hashimoto.
thyroiditis. So what happened in Hashimoto's thyroiditis? The antibodies caused thyroid inflammation, and following inflammation there was scarring. And if there is scarring, the thyroid gland was destroyed, TPO levels were depleted, and that's why Hashimoto's presented with hypothyroidism. Okay? That's the hormone synthesis and the steps. Next, let's talk about radioactive iodine uptake, where you're measuring the uptake by the thyroid gland. So any condition where the glandular activity has increased, the uptake will increase. If the glandular activity is suppressed, what will happen to the uptake? Decreases. So if uptake by the thyroid gland is high, what will happen to the urinary excretion?
Decreases.
If uptake is less, that means it will be excreted. So sometimes they just ask you that urinary excretion is less, so you have to assume that the uptake has increased. So based on this, if you have a graph where this is the normal uptake with respect to time, any graph which is upward, that means increased radioactive uptake by the gland, decreased urinary excretion. If the graph is lower down, decreased uptake, that means increased urinary excretion. So give me the following conditions I'll list out, and you have to tell what happened to the uptake. thyroid adenoma. So in thyroid adenoma, what happened to the glandular activity?
Increases.
It increased, so it's going to be an A.
So it will be A. Next, Graves' disease. What's Graves? Tell me about Graves' disease. It's again autoimmune, but antibodies here are what? Similar to what?
TSH.
TSH. So what will happen to the thyroid gland? It's continuously getting stimulated. So what will happen to the uptake?
It will increase.
It will increase. Will they have goiter, swelling?
Yeah.
Yes. What will happen to the TSH levels in Graves?
Decrease.
Decreases.
Because of negative feedback, TSH is actually less, but antibodies keep stimulating the gland, so the uptake will be increased and the patient will have a goiter. And what's the toxic feature seen in Graves because of inflammatory mediators? What's that one peculiar feature? Along with goiter, what else will they have?
Exophthalmos.
Exophthalmos. Good. Along with other features of hyperthyroidism. Next, in Hashimoto's, what happened? We already did the pathology I explained just now. The TPO is destroyed. Thyroid gland activity is less. So what should happen to the uptake?
Decrease.
Decreases.
Increases. B. What is endemic goiter?
Iodine deficiency.
Iodine deficiency. The thyroid gland is fine, but the iodine is less. So T3, T4 was less. So they are hypothyroid. But what will happen when you give radioactive uptake? Because of TSH, what will happen to TSH in these individuals? T3, T4 is less. TSH is high. It keeps stimulating the gland. So what has happened to the glandular activity here? Gland is fine. And because of stimulation by TSH, what will happen to the radioactive uptake?
It would increase or decrease.
So endemic goiter means they come with hypothyroid. But was there a problem with the gland? No. They did not have the substrate. Because of that, their TSH increased and it kept stimulating the gland. So what will happen when you give them the radioactive uptake? The uptake is actually going to increase. What happened in exogenous T3, T4? And why was that person taking T3, T4? Maybe in weight
loss.
loss. So their blood T3, T4 will increase. So they will come with symptoms of hyperthyroid, correct? But what will happen to the radioactive uptake? Because the blood levels were high, what happened to the hypothalamic pituitary thyroid axis?
They decrease.
So negative feedback.
Because of negative feedback, the thyroid gland was suppressed. So these individuals will have atrophy of the thyroid glands. Therefore, what will happen to the uptake? Even though they are hyper, what will happen to their radioactive uptake? It will
Decrease.
less. That's about the radioactive uptake and the changes. Based on this, I'll give you a break, don't worry, I'll just complete thyroid disorder. Tell me what happens to TRH, TSH, T3, T4. Will this individual have goiter? So what's the requirement for goiter? Either overstimulation of the gland or the tumor in the gland itself. So both is goiter. Goiter means nothing but enlargement. So what are the two causes for enlargement? Glandular hypertrophy by itself or overstimulation. And for overstimulation, who's going to overstimulate it by increased TSH? Next, what's the connection? Why will these individuals have prolactin-like symptoms? Amenorrhea. You already told me this before. Galactorrhea. So why will these individuals have this? High levels of TRH can stimulate prolactin secretion. Okay, so you have to relate it with TRH. Okay, I'll just mix it up. Primary hypothyroid. Secondary, I don't have space, I meant to write hyperthyroid. Tertiary hypothyroid. Primary hyper. Secondary hypo. And tertiary hyper. Okay, so start from the problem. Primary hypo, where is the lesion?
Thyroid gland.
Thyroid gland has a lesion. So T3, T4 is less. What will happen to TRH and TSH?
Hormone increase.
Can they have goiter?
Yes.
Yes, provided the gland should be able to respond. So in endemic iodine deficiency, they will have goiter. But if it is Hashimoto's, they won't have a big swelling, because if the gland is destroyed in Hashimoto's, there might be a diffuse swelling, but they don't have a really big goiter like in endemic goiter. So they may have goiter provided the thyroid gland is responding to it. Okay. Will they have prolactin-like symptoms? What has
Yes.
happened to TRH?
Yes.
Yes. Secondary hyper is the tumor. Where is the tumor?
Anterior pituitary.
Pituitary.
So because of that, TSH is high, T3, T4 is high. Due to negative feedback, what happens to TRH?
Decrease.
Will they have goiter? Decreases. Will they have
Yes.
goiter? May be there, but will they have prolactin-like symptoms?
No.
They cannot have prolactin-like symptoms. Not there.
Dr.
Tertiary.
Prajna,
Yes.
what if the T3, T4 would be less in secondary hyper?
Hyper is tumor, right?
Yeah.
TSH is high. So why should T3, T4 be less?
Oh, okay. I got it.
So
I think I got confused with something else. I got it though. Thank you.
TSH is high, T3, T4 is high. Due to negative feedback, TRH is less. Okay. So there will be goiter, no prolactin-like symptoms. Tertiary hypo, the hypothalamus is the lesion, having a lesion. So everything will decrease. And if everything decreases, they won't have goiter, they won't have prolactin-like symptoms. Primary hyper, where is the tumor?
T3, T4 increase.
Thyroid gland.
Thyroid gland has the tumor. So T3, T4 is high, and due to negative feedback, these two will decrease. Will they have goiter?
Yes.
Yes.
Because the tumor is in the thyroid gland, they will have goiter. TRH is less, so will they have prolactin-like symptoms?
No.
No.
No. Secondary hypo, where is the disease, defect?
They say
Pituitary.
So TSH is less, T3, T4 is less, and TRH tries to correct it. Will they have goiter?
No.
Will they have prolactin-like symptoms?
Yes.
Yes.
Tertiary hyper, the hypothalamus has a tumor. So everything will increase. They can have goiter, they can have prolactin-like symptoms. And the causes for secondary hypo, where anterior pituitary was affected, I've discussed two conditions which can suppress anterior pituitary. What are they?
Sheehan's and craniopharyngioma.
Sheehan's, craniopharyngioma. For tertiary hypo, that means TRH is not reaching, the TRH secretion is not happening. So any hypothalamic lesions, correct? So indirectly, what a stalk lesion where TRH is not reaching the pituitary can decrease everything. Okay, so that's about the different thyroid diseases. Okay, I'll give you a break at 11. I'll complete thyroid. So when you come back, we will discuss calcium, adrenals, and if time permits, pancreas. So because of that, in hyperthyroidism versus hypothyroidism, I've discussed the individual diseases, Hashimoto's, Graves. But in general, what are the other clinical features in hyperthyroidism? What happens to BMR?
increase.
Thyroid is excitatory, so BMR increases. What will happen to heat production?
Increase.
So what intolerant they'll be? They'll have,
Oh.
there's too
Heat
much heat,
tolerance,
there's
yeah.
too much heat, so it is heat intolerance. Weight,
Skin.
Weight loss.
weight loss, correct? They'll have weight loss, blood sugar can increase. So what does it do to proteins and fats? It tries to increase blood sugar by breaking proteins and fats. So protein catabolism, fat breakdown, blood sugar can increase. Blood pressure, heart rate,
Increases.
Increase.
ventilation. You need oxygen, so ventilation should increase. So respiratory
Alkalosis.
alkalosis. Okay. What does it do to GIT? It's having an excitatory effect everywhere. So GI motility will increase. So what will that individual have? Diarrhea. CNS also, its excitability increases. So what will happen to CNS reflexes?
High.
Hyper.
Hyper, exaggerated. What's the action of thyroid in cholesterol? It helps in removing circulatory cholesterol. So what can happen to blood cholesterol?
Decrease.
Decrease. It converts beta carotenes to vitamin A. So what will happen to vitamin A levels in this patient?
Increase.
Increase.
It converts more and more, so it will increase. Hypothyroidism in a child, you already told me, it's called as cretinism. In adults, what do you call it as?
Myxedema.
Myxedema. That's in adult, because adults don't have mental retardation. Child will have mental retardation, infantile body proportion, etc., along with other features. In adults, it's called mixed edema. So what's the most important clinical feature? Edema. Why is edema happening? Because of protein accumulation. Since it is proteins, what type of edema is it?
Non-pitting.
Non-pitting edema.
Non-pitting edema. Plus, sugar can drop, proteins will accumulate, fats will accumulate, BMR will
Increase.
decrease, heat production will decrease. So what will they have? Cold
Intolerance.
cholesterol
Hi.
high, beta carotenes are not converted, so that results in beta carotenemia, where there's yellowish discoloration of only the skin, not the sclera. Reflexes, it decreases them, so reflexes will decrease. And what's the GIT symptom they might have?
Constipated.
They have constipation, because the GI motility is less, constipation. Okay, so that's the critical diseases. Plus Graves, they'll have
Dr. Rajna?
exophthalmos in Graves, yes?
For respiratory alkalosis, right? Which one is with the plasma protein? I forgot. I'm sorry. When the plasma
That is
protein
in
attaches
tetany.
protectiny.
Tetany, if CO2 decreases, it gives rise to respiratory alkalosis. So here also it can cause. At an alkaline pH, the plasma proteins ionize. Since they are negative, they go and form complexes with positive ions. So free ionic calcium will decrease, resulting in tetany. So here also any respiratory alkalosis can actually induce tetany. Okay?
Got it. Thank you.
So now you can take your break. We'll take a 10-minute break. At 11:10 I will come back and we will continue whatever time is available. And I'll try to finish today, because honestly, reading concepts you are already good with. This is just a quick revision. Next 2 days I want you to seriously sit and do as many questions as possible. That's the key to doing really well on one shelf. Okay? Yeah. So I'll see you in by 11:10. Okay? Thank you.
Thank you.
Dr. Rajna, I have a question,
Sure.
please.
Tell me.
Okay, so with regards to cretinism, when you perform the Babinski sign test,
Correct?
it's to be done, that's like neonatal screening, right? Less than 2 years old?
Yeah, less than 2 years. No, it's a normal finding in most of the children, because myelination is not complete. But progressively, even after that, if it's persistent, then you have to look for hypothyroidism. But by then, no other features also will be visible. Babinski sign is not very much confirmatory, because up to 2 years it can be a normal finding, correct? So for
Right.
cretinism, you will look for the mental retardation by just looking for the developmental milestones.
Okay.
So that those
So
will be
that's like
more
the
like,
tongue protrusion and then like the reflexes, etc.
yeah, the tongue
Like
protrusion might be there because of hypoglossal weakness, plus all the primitive reflexes, suckling, pouting, abdominal reflexes, all will be delayed, slow, sluggish. Plus what's going to happen, even the developmental milestones, social smile, okay, that will be absent. And
Okay.
for the developmental milestones, it will depend. Some kids just take a longer time. It's not like the kid has to walk by 1 year. All kids don't walk by 1 year. You have to give a margin. And if you feel that it's unduly delayed, then you have to rule out hypothyroidism.
Okay, thank you.
Babinski's, as you told, is a normal finding in children less than 2 years. So that may not be the only feature, but I've seen a question where they told you Babinski's is positive. So that just means that myelination was affected, correct? And maybe
Right.
that kid was an older kid they have mentioned, not less than 2 years. Okay?
Okay.
Yeah.
Thank you.
You're right. That's a good question. Thank you. Okay guys, can we continue? I think you all are here.
Yes.
Okay, thank you. So we were looking at thyroid. Plus, I missed out the TSH stimulation test and TRH stimulation test. So remember, stimulation tests are done only in hypothyroidism to find out where is the lesion. So when we do TSH stimulation, TSH can affect only T3, T4, right? So your response will be based only on T3, T4. So on giving TSH, when they come to you, their T3, T4 will be less because they are hypothyroid, correct? On giving TSH, if T3, T4 increases, where is the problem? Are they responding? Are you with me, guys?
Yes.
Are they responding? Yes. So thyroid gland is okay. Where is the problem?
Anterior pituitary.
Anterior pituitary. On giving TSH, if T3, T4 does not increase, then who is not responding?
Thyroid gland.
Thyroid gland. Now for TRH, there's two responses. You have to look at what happens to TSH and T3, T4. So based on that, you might have three types of responses. Okay. And all this is done following TRH administration. So following injection of TRH, you're seeing what happens to TSH and T3, T4. So in the first condition, TSH increases, T3, T4 does not increase. So which level it's not responding?
The thyroid gland.
So thyroid gland has a lesion. In the second condition, both are increasing. That means pituitary and thyroid gland is fine. So where was the problem?
Hypothalamus.
Hypothalamus had a problem. Good. In the last one, both are decreased. Even after giving TRH, TSH is less, T3, T4 is also less because of that. So at which level it's not responding?
Anterior pituitary.
The anterior pituitary is not responding. And if anterior pituitary cannot respond, T3, T4 will also be less. So these tests help you to find out at which level is the lesion. Okay. Now moving on to calcium regulating hormones. What's osteoporosis? Which cells are hyperactive?
Osteoclast.
Osteoclastic activity is increasing, resulting in weakening of bones and osteoporosis. Why women are protected against osteoporosis up to menopause? What helps?
Estrogen.
Estrogen. So in short, what will estrogen do to the osteoclastic activity? Inhibits. So it inhibits the cytokines which can stimulate osteoclast. Okay, and it favors the cytokines, the transforming growth factor, which can cause apoptosis of osteoclasts. So in short, it inhibits the osteoclastic activity. Next, if a person is on a space flight or if they are immobilized, what's a common thing in both these conditions?
There's no mechanical
Stimulation.
No mechanical stimulation, so osteoblast decreases.
There's no mechanical stimulation, so your osteoblast activity is suppressed, and who takes over? Clast. There's osteoporosis, where the bones will release the calcium. So what will happen to serum calcium and serum phosphate?
They both
Increase, because osteoporosis, so bones are releasing, correct? So serum calcium and phosphate will increase. If serum level increases, what will happen to filtered load as well? Increases. Therefore, what will happen to urinary calcium and phosphate also? Filtered load is GFR times plasma concentration. So whenever plasma concentration, filtered load will increase. So urinary levels will also increase. Since calcium is high, how will that affect? What will happen to PTH, vitamin D and calcitonin?
PTH and vitamin D will decrease, calcitonin will increase.
Correct. So you don't want calcium to increase more. So PTH and vitamin D will inhibit. Calcitonin can excrete the calcium. So calcitonin levels will increase. So these are the changes seen in spaceflight or prolonged immobilization. Next, come to PTH. What secretes PTH? Which cells? Chief cells of the parathyroid gland. And what does PTH do to your blood calcium and phosphate levels?
increases.
Increases calcium, decreases phosphate.
It's increasing calcium, but it thrashes out phosphate, so it decreases phosphate. So how does it increase calcium and decrease phosphate? Its main action is on the kidney. So what will it do on the kidney? If it has to decrease the phosphate, what should it cause? Phosphate
Yeah.
excretion. It will inhibit the phosphate pump, which is the sodium phosphate cotransporter. It inhibits it. In which part of the renal tubules? P for P, phosphate,
PCT.
PCT. If it is increasing calcium, what should it favor? Calcium reabsorption. Which part? Early distal convoluted. So in the early distal convoluted, there are receptors for PTH. So PTH will bind to that receptors and stimulate the sodium calcium exchanger. So it wants to increase calcium, so it will reabsorb calcium. Now on the bones, so that's how it increases calcium and decreases phosphate. So on the bones, just concentrate on calcium. If it has to increase calcium, what should it favor on the bones? It should give calcium or take calcium?
Take calcium.
If it takes, it will decrease. No? On the bones, I'm asking.
It should give calcium, so it will favor the osteoblastic activity.
Yeah, I mean, you meant to say it should take calcium from the bones. I think that's what you meant. That's correct. So it should mobilize calcium from the bones into the blood. So what should it stimulate? Osteoclast. But PTH receptors are not on the clast. It's on the blast. So PTH will bind to its receptor, release of cytokines, which then stimulate clast. On the GIT, do we have PTH receptors?
No,
No, it cannot work. But what does it do is, it stimulates which enzyme on the kidney?
1-alpha hydroxylate.
And forms 125 dihydroxycholecalciferol. So with this vitamin D, then it will favor calcium absorption. Okay, so that's how it increases calcium and decreases phosphate. Let's talk about vitamin D. What does vitamin D do to serum calcium and phosphate? It increases both. How does it increase both? Its most important site is on the GIT, where vitamin D is fat soluble. So it will enter the cell and bind to its receptor, stimulate protein synthesis. And what's the protein it synthesizes? Cal-bindin D. So this cal-bindin is responsible for calcium complex to take the calcium into the blood. So that's how vitamin D will cause calcium absorption in the GIT, and also it will favor phosphate absorption. For phosphate it does not need a specific carrier. For calcium it will need cal-bindin D. So vitamin D forms cal-bindin D. So that's the reason it increases both. So if it increases both calcium and phosphate, what will happen to solubility product, which is a product of calcium and phosphate? So if both are increasing, what should happen to the solubility product? Increase. And because it keeps the solubility product high, what does it favor? Mineralization or resorption?
Mineralization.
If solubility product is high, you have good calcium and phosphate in the blood, so that will favor bone mineralization. So that's the main action of vitamin D. It makes sure that the solubility product is maintained, so your bones can mineralize. On the kidney again, it's increasing both, so it should favor reabsorption of both calcium and phosphate. Okay. On the bones, what is its action? It has action both on blast and clast. Depending on what is needed, it will work. So it will help in bone mineralization. But if the solubility product decreases for any reason, it can stimulate clastic activity so that it maintains the solubility product. So its main action is to maintain the solubility product and keep your bones strong. So if vitamin D is deficient in a child, what do you call it as?
Rickets.
Rickets. In adult, it is called as osteomalacia. So in both these conditions, vitamin D is less. So what has happened to calcium and phosphate?
Decreased.
Has decreased. Correct? Because it increases both have decreased. And what happened to solubility product because of that? Decreased. So because of that, your bones did not get mineralized, giving rise to osteomalacia. In children, there are bony deformities, knock-knee, bow legs, and these bony deformities, that's why it's called as rickets. What are the causes for vitamin D deficiency? What are the possible causes? Follow the pathway. From where did we get vitamin D? Diet. So if you're not taking enough, exposure to sunlight, if you're not going out in sunlight, any liver or kidney disease. Okay. So in chronic renal failure, what can happen to erythropoietin secretion? Decreases. What will happen to 1-alpha hydroxylase activity? Decreases. Because of that, what happens to active vitamin D levels? Decreases. So sometimes with renal failure, they ask you all these changes. Just be aware of it. Okay. Now what about calcitonin? What does calcitonin do? So you already covered hormones which increase calcium. So this last hormone should decrease our calcium and phosphate in the blood. Okay. So who secretes calcitonin? The parafollicular cells of the thyroid gland. So how does it decrease both? So what should the action on the bones be?
Osteoblastic action.
It's depositing them, right? So it stimulates blast and inhibits clast. So it makes our bones strong. And which two physiological ages or stages do you need the bones really strong? During growth and in pregnancy. So during growth and pregnancy, the calcitonin levels are higher because it inhibits osteoclastic activity, keeping bones strong. Okay. What should it do on the GIT and kidney? It's decreasing blood levels. So in both of these, what should it favor? Absorption or excretion?
Absorption.
It's decreasing your blood levels.
Excretion.
It should favor excretion. Now with that, let's move on to PTH diseases. Where you have the disease, comment on PTH levels. Tell me what happens to cyclic AMP levels. Tell me what happens to serum calcium, serum phosphate, urine phosphate. So I'll just randomly give you the disease. So in a parathyroid adenoma, which involves chief cell, or they might call it as chief cell adenoma. Start, what happens? What's the first problem?
You have an increase in PTH.
PTH is very high. So what will happen to cyclic AMP as well?
Increases.
And here PTH increases and it can act on all the sites. Bone, kidney, and via vitamin D can also act on GIT, correct? So because of that, what happens to serum calcium?
Increase.
Increases significantly. Phosphate will decrease. Urine phosphate will increase. Hypercalcemia, what can it predispose to? What will be the clinical features?
Renal stones.
Renal stones. And how did it cause hypercalcemia? What will it do to the bones?
It will break it down.
It will break it down. So in an attempt to increase calcium, it breaks down the bones. So these individuals will have osteoporosis, bone pains, stone formation in the kidney, stones, bones, groans, etc. Next, what's a cause for primary hypoparathyroidism? Where the parathyroid chief cells are damaged. What's the most common cause for this?
The chief cells are damaged, so they don't have PTH.
Correct. So what's one common cause? Yes, thyroidectomy.
Okay.
So in thyroidectomy, the parathyroids are damaged. So what will happen to PTH?
Okay.
Decrease. Cyclic AMP also decreases. Serum calcium,
Decrease.
serum phosphate is not excreted. So urine phosphate will decrease. Now next is chronic renal failure. So in chronic renal failure, start from the kidney problem and associate everything to the kidney problem. Don't go to PTH directly. Because the kidney did not work.
You don't have the 1-alpha hydroxylase?
Correct. 1-alpha hydroxylase does not work. So vitamin D is a problem first. Due to which, what will happen to serum calcium?
It's going to decrease the calcium levels.
So that will stimulate PTH. So what will happen to PTH?
It will increase rapidly.
And cyclic AMP will also increase. But what's the limitation here? Even though PTH increases, where can it act?
Only on the bones.
Only on the bones. Because of renal damage, kidney can't help. No vitamin D, so GIT can't help. So the only organ which can help are the bones. So hypercalcemia is not commonly a feature. Calcium might slightly increase, not much. Because of renal failure, GFR is less. So if GFR is less, where will it accumulate? What will happen to serum phosphate?
Increase.
And urine phosphate will decrease. Next, Albright's hereditary osteodystrophy. The other name for it is pseudo hypoparathyroid. So start from the problem. Type 1A, there is a defect in G protein. Other subtypes, the receptors may be defective. Doesn't matter. Whatever the cause, cyclic AMP is less. Therefore, what will happen to serum calcium?
Decrease.
And serum phosphate will increase, urine phosphate will decrease. And because of hypocalcemia, it acts as a stimulus. So what will happen to PTH levels? They are high, but they cannot act. So that's why it's called as pseudo hypoparathyroidism. Yes, Janai?
Hi, sorry, in the chronic renal failure one, why does the serum phosphate go up?
Because no, here you are associating with the renal failure, the primary disease, correct? So because of kidney damage, GFR is less. So filtered load will be less.
Right.
So where will it accumulate? In the plasma, phosphate.
Okay, right, that makes sense.
Yeah, I don't relate to PTH here. You have to relate it to the renal failure.
Okay.
Yeah, it's a bit tricky. Yeah, this is a bit tricky. Everything you relate with renal failure in this case. So that is Albright's. So in Albright's, what are the special features apart from hypocalcemia? What are the other signs you see?
The 4th and 5th metacarpal are short.
So shortening of the 4th, 5th metacarpals, giving rise to archibald or dimpling sign. Dimpling means you don't have a, they'll have a depression. They don't have the normal knuckles. So that's called as the dimpling or the archibald sign, which just means that 4th, 5th metacarpals are shortened. Plus, these individuals have associated cortisol excess. So they'll also be chubby, having Cushing's-like features. Now in primary hypo, PTH and cyclic AMP are less. In Albright's, PTH is high, despite which cyclic AMP is less. So when you give injection PTH in primary, what should happen to cyclic AMP after PTH in primary?
It will increase.
It should increase. So urine levels will be increasing. But in Albright's, PTH will not respond. Cyclic AMP continues to be low. What are we left with? A carcinoma lung breast. So here you remember it's not secreting PTH exactly, it's PTH-like peptide, which will use the same receptors. So what will happen to cyclic AMP?
Increases.
So it will act like PTH on all the sites. It can act everywhere, and via vitamin D it can also act on the intestine. So because of that, serum calcium will increase significantly. So they'll have stones, bones, groans. What will happen to serum phosphate?
Decrease.
And urine phosphate will increase. Because calcium is high, that will act as a negative feedback. So what happens to endogenous PTH secretion?
Decreases.
Decrease. So this combination where PTH is less, cyclic AMP is high, should tell you somebody else is acting like PTH. That's RP. PTH, RP. So that's with diseases. So let's talk about hypocalcemia. So in hypocalcemia, it gives rise to a clinical condition called as tetany. So what is tetany? There's increased neuromuscular excitability. Why? Calcium helps in closure of the inner sodium gate. So if there's less calcium, there's a delayed closure, due to which depolarization is prolonged that compensates on repolarization. So resting membrane is closer to the threshold. And if resting membrane is closer to the threshold, neural excitability will increase. So what will they present with? Spasms. Mild stimulus also can cause spasms. Carpopedal spasm, laryngeal spasms. They're very sensitive. So there is perioral tingling, numbness sensation. Okay, so if a patient comes only with tingling numbness, you're not sure, there's no carpopedal spasm. So what are the two signs which you will use to elicit tetany?
The Traurin sign and the Chopstick.
Chopsticks and Trossu sign. Trossus use the BP cuff, raise the pressure, look for carpopedal spasm. Chopsticks, C for cheek, tap the facial nerve and look for contraction of the facial muscles. Okay, so that's the clinical manifestation, tetany. Whereas tetanus, someone mentioned that time, there the inhibitory neurotransmitters are not released. What are they? Glycine and GABA. And if inhibitory neurotransmitters are not released, which channels cannot open? Chloride.
Chloride.
Chloride, inhibitory. So inhibitory potentials, postsynaptic potentials are not generated. So because of that, the motor neurons are continuously stimulated, which will not allow calcium to go back. So that causes sustained contraction. Whereas tetany is hypocalcemia. It's not calcium is increasing. In tetanus, there's increased calcium. Whereas tetany, the calcium is less. Why is it causing these effects? Because it increases the neural excitability. Okay. Then the other thing what I think you already asked me. So if a person is hysterically hyperventilating, they can develop perioral tingling, numbness, carpopedal spasm, tetany. Why? Always start with the problem. They are hyperventilating. So what happens to CO2?
Low.
pH will alkaline, and that will ionize plasma proteins which are negative. They will go and form complex with positive calcium. So they will bind to calcium, and what will happen to the free ionic calcium level? Decreases, and that results in tetany. So for this, the treatment will be just paper bag breathing. Whereas if it's because of a PTH disorder, you have to correct the disorder. If it's hysterically hyperventilating, they don't have any underlying pathology, paper bag breathing will help. Otherwise not, you have to correct the problem. And that concludes calcium. So next move on to adrenal glands. So we'll talk about the enzyme defects. 21, 11 beta hydroxylase deficiency. 17 alpha hydroxylase deficiency. Comment on what happens to cortisol, aldosterone, androgens. So what will happen to the pubic axillary hair growth? What will happen to sodium, potassium, H plus, and other features we can see. So okay, start about the enzyme defects. 21 or 11 beta, the downward pathway will be affected. Okay, so if 21 is affected, even the weak mineralocorticoid is not formed. So 21 is more severe. Hypotension is more severe in 21. And both these downward pathway, they are required for formation of which two substrates?
Cortisol and aldosterone.
Correct. So if 21 or 11 beta, cortisol and aldosterone cannot form. So what will happen to all the pregnenolone which is remaining? It will form excessive androgens. Okay, so all the pregnenolone which accumulates will form excessive androgens. So what will that result in? Congenital virilizing adrenal hyperplasia. So in females, the external changes are like males. So that is called as female pseudohermaphroditism. So external genital organs. What will happen to the clitoris? Enlarge, hirsutism, pubic hair growth, etc. will increase. Hirsutism, male-like body development. Breast will atrophy. Aldosterone is less, so what will happen to sodium? Decrease. Potassium and H plus will increase, giving rise to metabolic acidosis. Now in 17 alpha, the side pathway is blocked. So you don't have the 17 hydroxy derivatives. And what is required? 17 hydroxy derivative will form cortisol and they're required for formation of androgens. Okay, so that's why cortisol and androgen will decrease. What will happen to the precursor pregnenolone? Everything will go and form aldosterone. So they'll have excessive aldosterone. What's the syndrome?
Cons.
Cons. Because of that, their androgens are less. So pubic hair growth will decrease, lack of axillary pubic hair. Cons. So what will happen to sodium?
Increase.
Blood pressure will increase. Potassium and H plus will decrease, giving rise to metabolic alkalosis. Even though blood pressure increases, they don't have edema. Their ECF volume is high, but they don't have edema. What's that phenomenon called as?
Aldosterone escape.
Aldosterone escape. So what is protecting them from edema? There is something which decreases their ECF volume. So what happens to the ANP secretion? If ECF volume increases, venous return will increase. So the right atrium releases ANP, due to which there is sodium water loss. Of course, it cannot compensate. So in the end, sodium has to be high. But because some sodium and water is lost, the Starling's force hydrostatic pressure does not increase significantly. So there is no edema. So they'll ask you what causes, what is aldosterone escape or why they don't have edema? Because of increase in ANP. What will happen to renin secretion? Blood pressure is high.
Decrease.
Renin secretion in Cons syndrome will decrease because their BP is already high. You don't want to increase it further. So renin will decrease. So I've discussed Cons here along with the enzyme defect. Plus, if androgen is less, in females there might only be lack of axillary pubic hair growth, but in males it can cause a problem, especially during fetal differentiation. So what will happen in these males? They don't have enough testosterone and DHT. So that can cause male. So that can cause male pseudohermaphroditism. Okay. So in a male, they are 46XY, testis is there, but in the fetal stage, the adrenal testosterone is less. So the overall testosterone is less, the DHT also will be less. AMH is fine. So what's happening to the internal in this male? The testosterone is not enough to cause Wolffian duct to proliferate. AMH is present, so the Mullerian duct also will regress. So what will happen to internal? They won't have any internal. DHT is less, so by default what will happen to external? They don't have enough DHT, so what will happen to external? Female. So it can cause male pseudohermaphroditism. Okay. This is 17 alpha hydroxylase deficiency in a male we are talking about. In females, no big problem because of androgen. Accessory hair growth might not be there. Axillary pubic hair growth will be absent. So this is one cause for male pseudohermaphroditism. Circadian rhythm I have discussed. Next is Cushing's syndrome versus Cushing's disease. Syndrome is primary, where cortisol is high, and as a result of negative feedback, ACTH is less. So what are the possible causes for cortisol excess? Where is the tumor?
Adrenal.
Adrenocortical tumor, or what else? An exogenous glucocorticoids. If somebody is taking glucocorticoids for a long period, that lady I described, right? She was taking it for acne and later she developed excessive cortisol. Disease is secondary, where ACTH is high. Because of that, cortisol is high. And what are the possible causes for ACTH being high? One is the anterior pituitary tumor, and the other one was an ectopic site, where it was carcinoma of the lungs secreting ACTH. Okay, so that's the main difference between syndrome and disease, and clinical features are the same. If it's an ectopic, they might also tell patient was coughing, hemoptysis and all that. But what are the features in Cushing's? What will happen to blood sugar? Increase. And how does cortisol increase to sugar? It stimulates gluconeogenesis. So what will happen to proteins and fats? They will catabolize, lipolysis, correct? Now cortisol mainly increases sugar by stimulating gluconeogenesis. But what is its contradictory effect on glycogen? What does cortisol do to glycogen? It stores glycogen. So by stimulating the glycogen synthase. And why is it storing glycogen? So that it helps glucagon to act unopposed. So even though it increases sugar, it mainly does it by stimulating gluconeogenesis. On glycogen, it has a contradictory effect. It stimulates glycogen synthase and stores glycogen so that it helps glucagon. So that's called as a permissive action. Okay. Plus, what will happen to blood pressure? Stress. Associate everything with stress. Blood pressure will increase. Immune system suppress. So what they have easy susceptibility to infections. Bones. What can excessive cortisol do to the bones? It causes stress on the bones. So what cells does it activate? Osteoclastic activity increases, resulting in osteoporosis. So to differentiate this, you have the dexamethasone suppression test, where you give a low or high dose of dexamethasone, which is nothing but synthetic glucocorticoid. So night you give, and next day morning you allow the negative feedback to happen, and based on ACTH and cortisol, you will get the inference. So this is the inference. What's your diagnosis? So let me write it down. Low or high dose. Okay, let's do the suppression test. Tell me about the first column. What does it mean?
There's a tumor in the cortex.
Either you give low or high dose, ACTH is undergoing negative feedback. So that means there's not an ACTH tumor, but cortisol is not getting suppressed. So it's a tumor secreting cortisol. You're right? Good. So it's an adrenocortical tumor. Next one, low or high dose. ACTH is not suppressed. Cortisol also is not suppressed because of that. So here, in the previous case, the tumor was secreting cortisol. But in this case, what's the tumor secreting? ACTH. And even with the higher dose, it's not getting suppressed. So that means it should be an ACTH tumor which is not on the axis. Which is not on the axis. So which is that ACTH tumor which is not on the axis? That's why even with the higher dose, it's not getting suppressed.
Lungs.
Carcinoma, ectopic site. So that is the carcinoma of the lungs. Good. Next one, low dose ACTH does not get suppressed. So cortisol also is high. But when you give a higher dose, it's getting suppressed. So this again has to be an ACTH tumor. But here it is on the axis. The tumor is on the axis. So what are we talking about?
Craniopharyngioma?
Anterior pituitary tumor. It's an ACTH tumor on the axis, so it's anterior pituitary tumor. Low dose itself is suppressing both. So is there a tumor?
No.
So this would
No.
be a normal response. Good.
Dr. Prajna, for the tumor that's on the axis, would it be like a craniopharyngioma or just an anterior pituitary in general?
Okay, you tell me. It's an anterior pituitary tumor which should secrete too much ACTH. That's Cushing's. If it's a craniopharyngioma, what does it do to the anterior pituitary? It's a tumor outside. So what does it do to an anterior pituitary?
Oh, okay. It
Suppresses.
compresses. Okay,
So
okay,
that
okay.
is ACTH deficiency. That could be actually adrenocortical insufficiency. So craniopharyngioma causes adrenocortical insufficiency, not excess. Okay?
Okay.
Yeah, that's a good question, but that's the difference. Now let's talk about primary adrenocortical insufficiency. Insufficiency, deficiency all means the same. Okay? Versus secondary adrenocortical insufficiency. So start from the problem. So in a primary insufficiency, where is the lesion or the defect?
Outside.
Primary, so which gland is
Oh,
affected?
yeah. The green one.
Adrenal cortex is affected, so all the three layers are affected. It might be an autoimmune disease, post-tuberculosis, anywhere. So because of that, what happens to cortisol, aldosterone, androgens?
Decrease.
All the three layers are affected, so they will decrease. And what will happen to ACTH?
Increase.
Increase.
It is similar to MSH. So what's the most important clinical feature here? Hyperpigmentation.
Hyperpigmentation.
You're adding color. So what's the other name of this disease?
Addison.
Addison's disease.
Addison's disease. So what's the name for this? Adding color. So that's how you remember. Primary is called Addison's disease. Then you also know all this, no? Sodium, potassium. Sodium decreases, blood pressure will decrease. Potassium and H plus will increase. Androgen is less, so there's lack of axillary pubic hair. Okay. Now secondary insufficiency, where is the lesion? Where is the,
Pituitary.
so the craniopharyngioma or an autoimmune destruction can cause anterior pituitary to get destroyed, not autoimmune. Autoimmune mainly affects the primary gland itself. Secondary could be of craniopharyngioma, Sheehan syndrome, anything can cause secondary insufficiency. So here ACTH is the problem. Because of that, cortisol and androgen will decrease. Aldosterone might drop transiently, but the renin-angiotensin gets activated, and the angiotensin 2 will activate which enzyme? The final enzyme, aldosterone synthase. So what will happen to aldosterone levels? It is kept normal. So aldosterone is not affected. What are the main differences? ACTH is less, so they don't have hyperpigmentation. Plus, because aldosterone is fine, blood pressure, pH, sodium, etc. will be normal because aldosterone is normal. What's the response to ACTH stimulation test? So if you give ACTH in primary, what will happen to cortisol? Does it respond?
No.
Cortisol will be low. What's the response to ACTH stimulation in secondary? When you give ACTH, what will happen to cortisol?
Hi.
It should increase. Okay. Then in some questions, they also ask you about the first step. Cholesterol gets converted to pregnine alone. Which enzyme? Cholesterol desmolase, that is stimulated by ACTH. So they have asked you where ACTH is defective, which enzyme cannot be activated? Cholesterol desmolase. So remember that first step as well. So that concludes adrenal, Cushing's and all those important things. What's pheochromocytoma? Tumor of
the medulla.
pheochromocytes, that's adrenal medullary tumor. So what happened to catecholamines? They're secreted in excess. what will be the clinical features? All the P's. Heart rate increases, so they'll have palpitations. Pupillary dilation. There's excessive pupillary dilation. So what will happen to their vision? They'll have poor,
Blurry.
blurry vision. So poor vision. Blood pressure can increase. So the pressure will increase, and if the pressure increases, they can have severe headache. Okay, so these are some of the clinical features. Heart rate, cardiac output, all that will increase. So what's the diagnostic test? Catecholamines get degraded as vanillyl mandelic acid. So excessive catecholamines, what will happen to urinary excretion of EMA increases. So that's diagnostic of pheochromocytoma. Insulin, glucagon. So insulin, what will it do to the blood sugar? It's hormone of energy storage. Glucagon is hormone of energy release. Insulin secreted by the beta cells of pancreas, glucagon by alpha cells. What does insulin do to the blood glucose? Decreases. Glucagon will increase. So with that in mind, comment on what does it do to the following steps. Gluconeogenesis, glycogen synthase activity, glycogen phosphorylase, which breaks down glycogen, glycogenolysis. Glycolysis is breakdown of glucose, and that's potentiated by the phosphofructokinase enzyme. What does it do to lipoprotein lipase and hormone sensitive lipase? So that will summarize all the actions of insulin and glucagon. So give me that, complete the chart. So if it decreases blood sugar, what should it do to gluconeogenesis? Yes? Inhibit. Glucagon is increasing blood sugar, it should stimulate. Hormone of energy storage. So insulin should store glycogen. Glucagon should release it. Glycogen phosphorylase, which causes glycogenolysis. Insulin should inhibit. Glucagon should stimulate the breakdown of glycogen. Insulin wants to reduce the glucose, correct? So it will break down glucose by stimulating the phosphofructokinase activity. Glucagon does not want to break down glucose, so it inhibits the PFK activity. Insulin stores fat, so it should stimulate LPL and inhibit HSL. Glucagon releases fat, so it should stimulate HSL, inhibit LPL. So these are all the enzymes. You are asked about some enzymes activation, so make sure you know all these activity. Just follow the simple chart. Okay, from the blood, glucose can either be stored or released. This blood glucose can break down by itself by phosphofructokinase, or gluconeogenesis can help in forming more glucose. So based on what the hormone does to glucose, comment on all the other enzymes. Diabetes, you're okay, right? So if a person has high insulin, C-peptide high, blood sugar high, what are we talking about?
Diabetes mellitus, type 1, type 2.
Decide which one.
Type 2.
Type 2. Where insulin is high, so C-peptide will be high, but the receptors are down-regulated, so it cannot work, sugar will be high. Insulin high, C-peptide high, sugar is low. What are you talking about? Insulin which is working. So what's that tumor which secretes insulin?
You have beta cells.
Beta cell tumor, which is
Beta cell destruction.
it's an insulinoma which is secreting insulin, and insulin works, so sugar will drop. Insulin is low, C-peptide is low, therefore sugar is high. So that's an autoimmune destruction of beta cells, that is type 1. But if the individual is say 30 years, then you're telling it is type 1. But if I'm telling you individual is 50 years, having the similar features, then what are we talking about?
1.5.
1.5, which is latent autoimmune diabetes of adults, where later on in life there is an autoimmune destruction of beta cells. So insulin and C-peptide will decrease, sugar starts increasing. So in type 1 and LADA, the treatment will be to replace insulin. Whereas in type 2, you have to give oral hypoglycemic agents, which will help in reducing blood sugar or increase the sensitivity by increasing receptors. So if a person has taken an overdosage of insulin, so he will develop false or factitious hypoglycemia. So if someone comes with factitious hypoglycemia due to overdosage of insulin, what will happen to blood insulin levels?
High.
When they're present, it's high, but did it come from the gland?
Low.
Did that insulin come from the gland? No. So what will happen to C-peptide compared to insulin?
It'll be low.
It will be low. So because of that, there's a drastic reduction of glucose. So first you have to correct hypoglycemia, and they are diabetics. So later on, you have to educate them on their insulin dosage, how they have to take it. Diabetic ketoacidosis is common in type 1, 2, LADA 1.5. So where do we find ketoacidosis? If there is
The
insulin,
type 1 and type 1.5.
so insulin deficiency, the HSL inhibition won't be there. So where was insulin deficient? In type 1 and LADA. Insulin was less, so inhibition of HSL is not there. So they will have diabetic ketoacidosis. Whereas in type 2, insulin is high, so HSL inhibition is spared. So most often they don't have ketoacidosis. I think with the limited time, last one, that insulin glucagon ratio, that you know, right? Insulin is hormone of energy storage. Glucagon is hormone of energy release. So if you follow this, it's easy. So in starvation, what do you want? Storage or release?
Release.
So glucagon will increase. So what will happen to the insulin glucagon ratio? Decreases. If somebody has taken high carbohydrate diet, you want energy to store. So what will happen to the ratio? Increases.
Increase.
So starvation, when your energy requirement is high, glucagon increases, so ratio will drop. If your energy requirement is not very high, then insulin will store it, so ratio will increase. If you infuse amino acids, so amino acids can directly stimulate the beta cells, but now I finished GIT, right? So in GIT, what did we learn? Amino acids can stimulate CCK, which will stimulate alpha cells. So out of two, which will increase more, direct or indirect stimulation?
Direct.
So insulin will increase more than glucagon. So what should happen to the ratio? Increase. Glucose gastric inhibitory peptide, glucose dependent insulinotropic peptide, has a stimulatory effect on the beta cells. So oral glucose or IV glucose, which is causing more insulin secretion?
IV.
If you give IV, it will only, the glucose itself will stimulate the beta cells. But when you give oral, the glucose plus GIP can stimulate. So in which insulin secretion will be greater? When you give an oral glucose load or IV glucose load?
Oral.
See, are you getting this? The beta cells, they can get stimulated by the glucose by itself when glucose increases, correct? So when you give an IV glucose infusion, this glucose will stimulate the beta cell and insulin will increase. But if you give an oral glucose load, along with glucose, it will cause the GIT to release GIP, glucose dependent insulinotropic peptide. So there is a double stimulation. So what will happen to insulin secretion? It increases more. So oral glucose can stimulate insulin much more than IV glucose. Are you getting this? Yes. So I think we have exceeded the time. Thank you for waiting. And that is pretty much with endocrine. So we have done most of the important stuff and I've completed endocrine. So it was a good review. And with that, I think that's all for now. Do you have anything else you want to go over?
I was hoping if we can go a little bit over the
Which one?
I was hoping if we can go over the
Sorry, I can't hear. Which topic?
You can hear me?
Yeah, now I can hear.
Can you hear me?
Yeah, one sec, there's some disturbance. Okay, can you tell me now?
Yeah, I was hoping if we can go a little bit over the GI.
GI, see wherever it's affecting like CCK and all that.
Yeah.
Yeah, if somebody wants to leave, you can please leave. Okay, you can leave if somebody doesn't want, but if you want a little bit of GI, I can do for another 10 minutes maybe. Okay, so when we did gastric hormones, GI hormones, correct? So those hormones topic is important. So what are the different GI hormones we have covered? Gastrin, secretin, what else? What are the GI hormones? Gastrin,
GCK.
secretin, cholecystokinin, and gastric inhibitory peptide, the glucose-dependent insulinotropic peptide. Can you hear?
Yes.
Okay.
Yes, again.
So gastrin, where does it mainly secreted from? Where is it mainly secreted from? The G cells. And remember, the gastrin is secreted into the bloodstream, and then it can go and activate the parietal cell. So what does it help in? Acid secretion. What's another important effect of gastrin? Whenever gastrin secretion increases, it has a stimulatory effect on the growth of or proliferation of the stomach mucosa. So if gastrin increases, it can cause the hypertrophy of the mucosa, gastric mucosa. So give me a condition where gastric increases, Zollinger-Ellison syndrome. So in Zollinger-Ellison, there's non-beta tumors, beta cell tumor, which secretes gastrin. So what will happen to hydrochloric acid secretion? H plus secretion increases. Do these individuals have gastric ulcers or duodenal ulcers?
Gastric?
For gastric ulcers, what should happen to the gastric mucosa? It should be
Oh,
weak.
no, you're right. Yeah,
It should be weak.
mucosis.
What did I just tell gastrin does? It actually causes hypertrophy of the mucosa.
Right.
So this acid will cause more damage to the duodenum, and duodenal ulcers will be commonly seen. Because that's another action of gastrin. It leads to hypertrophy of the mucosa. So actually the mucous cells are hyperactive and the mucus secretion is slightly more here. So because of that, the duodenal ulcers will be seen. Next, because acid is high, what will it inactivate? Pancreatic lipase. So along with duodenal ulcers, what else will these individuals have? Steatorrhea. Because lipase is not there, fat digestion is affected, fats are excreted in the feces. Secretin is called as nature's antacid, correct? So antacid means it should secrete bicarbonate from all the sides. So it will stimulate the secretion of bicarbonate. Okay? In the pancreatic secretions everywhere, it will stimulate bicarbonate secretion. So all the other three hormones are released from the intestines. Gastrin is released from the stomach. So what did I tell? Any hormone released from the stomach, what will it do to the GI motility? It stimulates it. Whereas all these intestinal hormones, what is their collective action? To inhibit GI motility. And why do you want to inhibit GI motility? You want to give enough time. Otherwise, if stomach keeps on dumping things, your intestine cannot handle it. So all the intestinal hormones have an inhibitory effect on the GI motility. Plus along with that, secretin is nature's antacid. So what will it do to the parietal cell acid secretion? Decreases. GIP is gastric inhibitory peptide. So again, what can it do to the parietal cell? Inhibits. Whereas CCK has no role on parietal cell, but it inhibits only the GI motility, not the secretion. Okay? CCK, it helps in contraction of gallbladder and relaxation of sphincter of OD. So when do you need bile? For fat digestion. So what should stimulate CCK? Fats, proteins, they can stimulate CCK secretion. Okay, that's how you relate CCK. Since it helps in release of bile, which is needed for fat, fats and proteins can stimulate CCK. So if CCK levels decrease, bile is not released. So what will that lead to? Biliary stasis, which can lead to stone formation. Okay. So what are the factors which can decrease CCK? If there's less fat in the diet. And who has less fat? If person is trying to lose weight. or if the person is on IV fluids. So weight loss regime, IV fluids, fat is less, CCK will be less, biliary stasis, bile is not released, so that can predispose to stone formation. Then
Dr. Prajna, question really quick. So if a patient has their gallbladder removed,
yes,
then would they technically, if they're increasing their fat intake in their diet, would they have steatorrhea then?
they might have, because when you're removing the gallbladder, you're doing a surgical procedure where you anastomose part of the GI directly to the second part of the duodenum, the ducts, right? So because of that, whatever bile is secreted will directly go to the second part. But because there's a limitation here, it can't function as a normal gallbladder, right? So there's a limitation. So if they take too much, that's why after surgery you ask them to restrict their fat intake. You're correct. Okay?
Okay.
Then cholelithiasis I discussed, right? So in gallbladder stones, biliary stones. So F4 Fs, fat, 40, fertile, female. So with age cholesterol problems might increase. Fertility is related to estrogen. What does estrogen do? It decreases the blood cholesterol levels. Or in other words, what will it do to the biliary cholesterol levels? It will increase. It tries to take it back. So in that process, it will decrease the circulatory levels and it tries to excrete cholesterol. Okay, so the biliary cholesterol levels will increase. Plus, any condition where CCK is less, that I just described, no? If there is decreased fat intake, that can inhibit CCK secretion, or somatostatin. Like everywhere else, somatostatin has an inhibitory influence on CCK. So in your practice questions of the case, I've given you a question where person is coming with increased somatostatin levels. So that should tell you that CCK is inhibited. And if CCK is inhibited, bile is not released. So that will lead to biliary stasis. And this can also contribute. What is the other component of bile? Bilirubin. So in any condition where bilirubin increases, and what can predispose to release of bilirubin? Increase in bilirubin. Hemolytic diseases, especially in children. So if they're telling you a child is coming with gallstones, most of the times it's because of bilirubin. So we call it as pigment stones. In an adult, which is more likely, cholesterol stones. Okay, cholesterol stones are transparent, but if calcium is incorporated in it, it gets opaque. Pigment stones are always opaque. Next, diarrhea also we did this morning, no? So in osmotic diarrhea, the osmotic particles are not getting absorbed, due to which it will drag water. And which was one osmotic particle? That would be lactose. So this is seen in lactase deficiency. Lactose cannot get reabsorbed, it cannot get absorbed, so there is osmotic diarrhea. Okay. What is secretory diarrhea? As I mentioned this morning, for some reason, the chloride channels are becoming hyperactive. Lumen is becoming negative, which will drag sodium and water, and that results in secretory diarrhea. So they will ask you these basic questions. In osmotic diarrhea, the solute concentration is less. Water is also less, so volume is lesser. In secretory diarrhea, the solute concentration is high, which drags a lot of water, so volume is greater. Okay? And what are the causes which stimulate the chloride channels? Cholera toxin, VIP, I explained the mechanisms, plus bile salts, if they are not going back, they remain in the intestine, which can also activate the chloride channels. So all these conditions can result in secretory diarrhea. Then the different segments, if they are affected, if the duodenal segment is resected, most likely they will have nutritional deficiencies, iron deficiency, calcium, magnesium, they will decrease. If person has undergone ileectomy, then what's the site, what was absorbed in the ileum? B12, what else? Intrinsic factor B12, so they can have B12 deficiency. Bile salts were getting recirculated. So what else will be less? Bile salts will be less. Okay, so they can have steatorrhea. Next, gastric versus peptic ulcers. Duodenal, I meant duodenal ulcers. So these are under peptic ulcer disease. You can have gastric ulcer or a duodenal ulcer. So one is site, gastric is in the stomach, duodenal is in the duodenum. What's the predisposing factor for gastric ulcer? Any problem with the mucosal membrane. For some reason the protective mucosal layer is disrupted. So what is in the mucosal layer? Mucus bicarbonate. So for some reason this is not getting secreted. So what actually normally causes the mucosal cells to act? Prostaglandins have a stimulatory effect which helps in production of mucus and bicarbonate. So if you give any drug, non-steroidal anti-inflammatory drug which inhibit prostaglandin by inhibiting cyclooxygenase, the protection is lost. Or what else was damaging the mucosa? H. pylori. What's the function of H. pylori? It has urease activity which converts urea to carbon dioxide and ammonia. This ammonia can damage the mucosa. Plus ammonia gets neutralized, ammonia will neutralize the acid. So what will happen to H plus in the lumen? It will keep decreasing. So what will happen to the parietal cells? It keeps secreting acid. Because the H plus is getting neutralized by the ammonia, the parietal cell keeps secreting H plus. So because of that, there is too much acid secretion. It's going on happening in a vicious manner. Okay? And for that you do the urease carbon dioxide breath test. So this carbon dioxide can be detected in the breath. So that's called as the urease breath test. So if it is gastric ulcer because of just NSAIDs etc., you just give proton pump inhibitors or H2 receptor blockers. Okay, but if they have H. pylori infection, you follow the triple therapy where you give proton pump inhibitor followed by 2 antibiotics to destroy this organism. And because the H. pylori is flagellated, it can also cause damage to the mucosa. Now duodenal ulcer is seen if too much acid reaches the duodenum. So that can cause ulceration. So the cause for duodenal ulcer is too much acid. Zollinger-Ellison syndrome, where the gastrin protects the stomach and this acid causes duodenal ulcer. Symptom wise, both have epigastric pain, but what's the difference? In gastric ulcer, when they eat food, it gets aggravated or relieved?
Aggravated.
It gets aggravated. Why? Because the food will directly irritate the mucosal membrane, which is ulcerated, no, in the stomach, so it will get aggravated. Whereas in duodenal, what will the food actually do? It will relieve the symptoms. Why? Because when we eat, where will the food first go? Before reaching duodenum, where will it first go? Stomach. So when it goes to the stomach, entire attention is focused on the stomach. So the stomach will start contracting. In that process, the duodenum is actually relaxing. So that will relieve their pain. Okay, so that's some major differences. So in both there can be bleeding, and that bleeding is altered blood. So that is called as melena. It's starry black stools. Okay.
The duodenal also is caused by the Helicobacter pylori, right?
It can be because too much acid, no? Your parietal, because what's happening in H. pylori, because this ammonia is neutralizing the H plus, the parietal cell keeps secreting H plus because the lumen H plus is decreasing. So the parietal cell keeps secreting H plus. So in the end, too much acid may reach the duodenum as well. Okay, so there can be duodenal ulcers, but H. pylori has a direct invasive effect on the gastric mucosa. So gastric ulcers are common, and ammonia also can cause direct damage to the mucosa. So in H. pylori, gastric ulcers are common. But because there's too much acid secretion, it can cause duodenal ulcers also. Okay?
Thank you.
Then breast motility, today I revised it, no? Achalasia cardia, Hirschsprung's disease. So all those clinical stuff is important. Make sure you read them. Okay? That's with GIT. Since you're still waiting, sex differentiation I just wanted to revise once. So in sex differentiation, start from the chromosomal pattern, and that's the genetic sex. If the chromosome is XY, it has to be male. XX has to be female. If there is Y chromosome, there will be presence of XRY gene unless otherwise. So in presence of SRY gene, the bipotential gonad will differentiate into the male gonad, testis, and this will be the gonadal sex. Females don't have SRY gene, so the bipotential, if it does not have SRY gene, by default will differentiate into the ovary. In the males, testis has Leydig and Sertoli. Leydig secretes testosterone, Sertoli secretes AMH, Mullerian inhibiting substance or anti-Mullerian hormone. So now let's go to the genital sex, phenotypic sex. So that depends on the internal genitalia and the external genitalia. So this classification is based on internal genitalia, means it has to be derived from the Wolffian duct, and in females from the Mullerian duct. External genitalia have to be derived from the genital tubercle swelling and folds. So now let's see in males. In males, the Wolffian duct has receptors for testosterone. So this testosterone will act on the Wolffian duct and differentiate into the epididymis, vas deferens, seminal vesicles. Now if males have Mullerian duct, that would have differentiated into uterus, etc., which we don't want in males. So that's the function of AMH. It will regress the Mullerian duct so that only male structures are formed. Tubercle swelling and fold have 5-alpha reductase enzyme. So when testosterone comes here, it gets converted to DHT by 5-alpha reductase, and this has receptors for DHT, which will differentiate into the male external genitalia, prostate, penis and scrotum. Now in a lady, she does not have testosterone, she won't have AMH. So her Wolffian duct cannot proliferate. She does not have AMH, so her Mullerian duct will proliferate and form the female internal structure, uterus, cervix, fallopian tube and upper third of the vagina. Whereas she also does not have DHT, so by default her tubercle swelling and fold will form the labia majora minora, clitoris and lower vagina. So if upper and lower vagina are not continuous because of a malformation, it can give rise to blind pouch. They have to be continuous. If any problem, they are not continuous, we call it as vagina as blind pouch. So once you know this normal, let's do some diseases. 46XX ovary, uterus, cervix, fallopian tube, hypertrophy of the clitoris, hirsutism. What are we talking about? Genetic and gonadal is female. So what should it be called as? Female pseudohermaphroditism. So why did she undergo virilization? What was she exposed to?
Increase in androgens.
Androgens. What's the disease we covered? Congenital virilizing, or if a pregnant lady was exposed to excessive androgens and if the child was a female child, it can cause the same effects. Next, so internal, external, everything is female. Ovary. So genetically it's a male. So that's why it has to be a male pseudohermaphrodite. But why testis was not formed? What was absent?
Androgens. Oh, I'm sorry. Yeah, that's for the internal.
Certainly so.
Testosterone.
The SRY gene was absent. So here there is a problem with the SRY gene. Correct? So the SRY gene was not working. So that's why the testis could not form. Okay. So again it is male pseudohermaphrodite because chromosome is male. Okay. Next one. The individual is XY, has a testis, has epididymis, vas deferens, seminal vesicles. External will be vagina ends as a blind pouch. Okay. Clitoris is hypertrophied. They don't have breast development, they don't have menstrual cycles, etc. So this individual externally was looking like female, but at puberty they developed other changes like hypertrophy of the clitoris, and they didn't get menstrual cycles at all. So what will you call this condition as? It's a male, correct? So male pseudohermaphrodite. Up to internal structure everything was fine. Only the external was female. So what did this male not have?
That upper reductive.
DHT was not there. So what are we looking at? 5-alpha reductase deficiency. And at puberty what happened? Testosterone is okay. So this testosterone led to hypertrophy of clitoris and more of masculinization. So that's why it's also called as penisexual syndrome. So that is with the disease. Correct? Yes, you're right. So that's 5-alpha reductase deficiency. Next ones. XY testis. They are having epididymis, vas deferens, seminal vesicles, uterus, fallopian tube, prostate, penis, scrotum present. So what happened here again? There was some problem. So again it's male pseudohermaphrodite. Here what happened? Everything is male, but internal what happened? They had both male and female. Why? What did they not have? The Mullerian duct formed the structure. So what did they not have? AMH or Mullerian inhibiting substance was not there. So Mullerian duct also proliferated. Correct. Okay. Now this individual, no, what happened? Genetic gonad, male. So it is male pseudohermaphrodite. Did I mention any internal? No. Vagina was blind pouch. Okay. So their external was female. So what happened in this individual? What are we looking at? Let's see what happened. Why they did not have internal? Their Wolffian and Mullerian duct was not working. Why did the Wolffian duct not work? Because the testosterone was not working. The Mullerian duct did not work because they had AMH. Okay? And why their external was not formed? Because they did not have DHT. So which is that disease where both testosterone and DHT cannot work? It has to be a problem with receptor. What is that disease? Androgen insensitivity syndrome. So externally, they look like females. And at puberty, what will happen? The testosterone secretion is okay. But only thing is because its receptors are not working. What did I tell you? If testosterone is not being used up, it gets converted to estradiol. So because of that, they develop breasts. So again, it's more of feminine features. So the individual might expect menstrual cycles, but will they have menstrual cycles? They don't have ovaries. So they won't have question of having menstrual cycles. So they will have amenorrhea. So if both internal and external is affected, it has to mean that testosterone and DHT both are affected. So it has to be androgen insensitivity. It could be androgen insensitivity syndrome. So either they ask you like this, or they'll ask you individual hormones. So if they tell you Leydig cells are destroyed, or in the other condition they tell you Sertoli cells are destroyed, or in the other condition there's castration. This castration happened. Sorry, castration can't be. So in castration it's male hypogonadism. So that's another thing. Here we are talking about fetal differentiation, correct? So we can't tell castration here. So let's see. Leydig cells are defective, Sertoli cells are defective, and if both Leydig cells and Sertoli cells are defective. So based on this, let's go one by one. If Leydig cells are defective, Sertoli cell is fine. They don't have testosterone, AMH is okay. So comment on internal and external.
Internal will be none.
They don't have testosterone, so male cannot. They have AMH, female also cannot. So internal is none. What is external? They don't have testosterone.
Female.
They won't have DHT. So external will be female. If Leydig cell is fine, Sertoli cell is affected. So they don't have only AMH. So everything will be like males, but because they don't have AMH, what will happen to their internal? Testosterone works, so they'll have male, AMH is not there. So Mullerian duct will also form, female. They have testosterone, so DHT is okay. So external will be male.
Male.
If both are damaged, then they can't form internal external of male. So
Will
by
be
default,
female.
it will be female. It's like in women, right? Both the cells are not working. So both internal external will be female. So that was one area. And then male female is okay, I think. Focus more on enzymes and all that. So those are important areas. Menstrual cycle, pregnancy, etc. So I think we can stop now. Thank you for whoever stayed back. So hope it was useful. Wish you all the best. Okay.
Thank you, Dr. Prajna.
And whatever those mock exam you have, no, please take
That was
it.
amazing.
Today we are going to have a mock exam again. It's new for me, so bear with me, whoever is in my room. I'll be messing things up. For the mock exam trial today, I think at 3 you all have, right?
Yes.
Okay.
Yes, at 3.
So maybe I'll see some of you again there. But hopefully everything goes well, and do more and more of questions, and all the best. Okay? Bye.
Dr. Prajna, thank you for everything. It was an amazing semester.
Yeah,
We
I too,
appreciate
it
it.
was a good semester for me.
You put a lot
Thank
of
you,
time.
everyone. Thank
Well, we
you.
appreciate it.
Thank you. Bye. It's mutual,
Thank you.
so make me proud. Just
Thank
more questions. Okay? Yeah.
Thank you, Dr. Prajna. I really appreciate your time.
Thank you, guys.
We'll make you proud on the show. I got you.
Yes, I mean, don't get stressed up. I'm just telling, do your best. Okay? Don't get stressed up now. If you get stressed up, it spoils the entire show. So tell yourself I'm doing my best, but do lots of questions. I think that's the secret in the end. Okay?
We will,
guys.
definitely.
We will.
Bye-bye.
Thank you. Dr. Brown,
Yes?
before you go, I have a quick question, sorry.
Yes.
Related to pheochromocytoma.
Okay.
And so is Addison's disease is a presentation of pheochromocytoma in a sense?
What's the connection?
Well, would it be adrenal insufficiency?
Okay, because of the tumor compressing, you're asking.
Right.
Yeah, you're right. Okay?
Okay.
So let me draw this out. I'll just take a blank.
Sorry.
Okay, I'll take a blank sheet. So you're right. Pheochromocytoma is a tumor of adrenal medulla. So if the tumor of the adrenal medulla, okay, if the size of the tumor is so big that even the cortex gets compressed. So adrenal medullary tumor can lead to an adrenocortical insufficiency. Right. So pheochromocytoma in extreme cases, depending on the size, it all depends on the size of tumor. So if it's suppressing the adrenal gland, it can lead to insufficiency. Right.
Okay. Okay.
That's it. Anything else?
No, that was my question. Thank you so much for your help.
Okay. Thank you also, Erika, and wish you all the best. Okay.
Thank you so much.
Bye-bye.
All right. Bye-bye.
Okay. Anybody else has any question? Okay, if nothing else, all the best, guys. I'll see you soon. Bye-bye.